welcome to our Boost webinar. It's actually the last webinar for Interior Boost. And yeah, welcome. If you want to type your name and location in the chat, that would be great. I do want to note, you would have seen already that this session will be recorded for educational purposes. So if there's any concerns with that, you can let us know. Yeah, so all of our webinars and our learning events are posted online or in case anyone missed them and wants to catch the recording of it. Just to note that if you can have your cameras on, it's always nice to see faces instead of kind of looking into the abyss, but also understanding that it's early in the morning. So totally fine if you want to keep it off. And I would like to begin by acknowledging that the land on which we gather is the traditional, ancestral, unceded, and occupied homelands of the Coast Salish peoples, including the 7 interior region First Nations, where we live, learn, collaborate, and work together. This region is also home to 15 chartered Métis communities. It is with humility that we continue to strengthen our relationships with First Nation, Métis, and Inuit peoples across the interior. We also want to acknowledge that others may be joining from different traditional homelands today. This acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous peoples in the healthcare system. I myself am joining in from the Musqueam, Squamish, and Tsleil-Waututh nations today. This is just a note that Boost is funded by Health Canada's SUAP program and the Shared Care Committee. And it's just a thank you to all our funders and partners, including our client partners and our family voices. We're going to have a couple of polls today. There was one up, actually we might launch it in a sec, and then there's one at the end, and then just a really quick long answer survey that'll pop up in your browser at the end of the webinar today. So we always appreciate you taking a minute or two to fill those out. So our webinar today is a little bit of a mix. We're going to have a Boost team spotlight. So Marcy Gofsky will be speaking a little bit more about the work that she's been involved with as team lead for two of the Boost teams. Andrew's going to speak a little bit more about the MHSU network with Interior Health and what supports and resources are available through that. And then we also have Deb Bailey here today. Deb's been involved with Boost for quite some time when it was provincial. She's a family member and she's also a member of Mom Stop the Harm Vancouver. So she's going to be speaking with us, and her talk today is called The Ones Marked with the X. So we will have time, I believe, for some questions as well after each of the presentations. So feel free to, when we get to that stage, either type in the chat or just let us know by unmuting yourself or raising your hand. So we're going to move along, and I will pass it over to Marcy. So as I mentioned, she has been the team lead for 2 of the teams, for Merit and LLA, which is Lillooet, Ashcroft, and Lytton. And she's been very busy since Boost launched. And she's going to talk to us a little bit about some of the work that she's been doing and maybe what, what they plan to carry forward from Boost. So I'm just going to stop sharing my screen here. And Marcy, if you're ready.
I'm here. I've got the tiny screen and I actually can't focus. So I'm not sure how to get out of this, to be honest with you.
Okay, like what you're seeing is a tiny screen?
Half the screen, yeah, it's really honestly not manageable. I don't know what the problem is, but I've got a chat taking up half.
Are you able to exit the chat?
And then it exits me right out. No,
I see.
The meeting, so I honestly can't. I'm on a tiny little laptop too, so actually I really don't know how to fix this. Okay, now I just got rid of everybody. All right, there we go. Yeah, I'm not good. I am like your worst nightmare for computers. Seriously,
it is confusing, even for someone who's used Zoom for a long time. You never know what you're going to encounter.
Like, how come it just did that? It split the screen in half. Yeah, so welcome. I'm calling in from Kamloops, from Secwépemc, and yeah, I really appreciate the opportunity to kind of wind down a little bit of the information from Merritt. I was looking after Merritt and LLA, which is Lytton, Lillooet, and Ashcroft. Lillooet being the larger center of the three, but Dr. Miller is our prescriber over for those 3 locations. And lots of challenges for sure along the way. I came into the Boost project a little bit tardy. I didn't start doing this project until September, and really had lots of challenges like everybody else trying to collect data. Neither of our prescribers are on profile, and just had varied we had varied capabilities of collecting information and getting data, and I ended up deep in the weeds of actual paper charts most of the time. And so that being said, we did end up getting reasonably good material across the locations. What was interesting in number wise and in demographics, because I had to collect some of the demographics later when we were kind of done with like age group data. What I found, because I also was in the clinics with Dr. Soderberg and Dr. Miller at times, just how much they matched. And in fact, the numbers, so the Merritt has a busy clinic, but when we actually extrapolated out to Lillooet, Lytton, and Ashcroft, similar numbers of clients, and actually a lot similar in terms of demographics. So same sort of age groups. You could pull age groups from Merritt and just like do a bell curve over to Lillooet, Ashcroft, and Lytton. Some of the differences that I think going forward we're going to find, I believe, because we're going to move forward with a couple of the goals that we had, is the much more remoteness when you're over on the west side of IH. You know, you're capturing places. There's no shelters except there's support in Lillooet, but there aren't places for people to really hang out. There's deterrence in communities to accessing oat medications, for example. Ashcroft's a humongous example of that. And so there's a lot of hidden, you know, we found that in our meetings with the doctors and the MOAs and also the clients when I was over there. We have huge obstacles still to maneuver around and to get through. And so Boost has afforded us the opportunity to engage in a way that maybe we hadn't. And sometimes we have to, in healthcare, really as close to the ground roots as we can possibly get to hear the stories. So for me, the storytelling was a big deal. Like Ashcroft, as an example, had an awful lot of people that are seniors and they're coming in for pain management. They have to attend an oat clinic for methadone, for pain control, for whatever reason. And the stigma that's attached to it for those that are having to attend an oat clinic came to our attention, that there's a lot of issues around that for those that are coming for maybe different reasons. But also we found some folks in that sort of over 50 age group in particular that that had some kind of surgery, be it a knee replacement, hip replacement, and regardless of the reason. It's not just aging for sure. Ended up addicted in these small remote communities, ended up addicted to opioids, and then found themselves having to be attended to. And we're missing those folks. They're afraid to come. So I think we're going to find with this project, with the Boost, is giving us the opportunity to kind of see that more clearly, look at it not just from age groups, but look at health conditions and our ability to manage that. Out of Ashcroft, now we were in a really good relationship with the UPCC Center over there, so the urgent primary care, with a novel project that's going on to provide oat medications with Dr. Miller still prescribing. But we actually successfully transferred, don't know if transfer is the right word, but we were able to get Dr. Miller at the end of Boost to move to profile through that experience and getting the UPC Center up and running. It became really obvious that, like, how are we going to document? And that was a gigantic step forward to be able to sort of see that transition without pressuring. You know, it just became really clear that that needed to happen for the benefit of the client. And so that's a really positive thing. I think moving forward, we've got a survey going right now. It's slow to get going, just we have no staff. So I think everyone experienced that. Since August of 2022, there was 1 month in merit. We had an admin. So all the months, we finally hired somebody last Thursday in merit. So there wasn't anyone to collect data. There wasn't anybody to turn to help. There wasn't anybody to hand out. And we were down to one nurse who's actually a float nurse. So I'm down there covering. I have to leave when I'm done here to get down there because there's no staff to give injections today. And so, you know, that just to encapsulate, not an all about me or all about merit or all about LLA, just how healthcare is right now when you're trying to do a quality improvement. That's so important and so necessary. And at the same time, face accreditation this week, deal with staffing issues, collect data. And sometimes the travel wasn't possible for me because I had other priorities, patient focused things that had to be done. What we're hoping to do moving forward with a couple of our agenda items is the sublocade part of our project. Excellent outcomes for remote rural. Those folks can't get transportation necessarily. They're heavily reliant on coming into the boost, coming into the Oak clinics or coming into clinics on a transportation that doesn't exist. There are no buses. There's no taxis in Ashcroft and Leiden. Lillooet, not so much better. There's a small bus service in Merritt, but it runs every hour. It's not conducive to those that are trying to get to an Oak clinic. People miss their appointments. And so that's an interesting challenge that we're feeling sublocade may be helpful with where appropriate. And then we had in our last go round, the phone reminders, but we have not had admin to do that. And so hopefully we'll be able to pick that up. We want to continue with that. What we did find, 8 out of 10 did not have a phone, and that was that Lillooet data. So it's a great concept. However, we'd have to be handing out, we have to do this differently. So that's where the peer coordinator, peer support worker, making sure we have funding for that. All sites, the clients have said, I was brought here by my friend. I was brought here by 2 friends. I was brought here by my brother. I was brought here by Ask Wellness. They're the ones that have a car to drive. We have to build those relationships. So that's come out of Boost as well. So having ability to get people to their appointments and connect as reminders is going to have to be for sure more about the connection with an actual human being and not a phone or a computer. We have to grasp that reality that this is a people thing. And we're relying on technology where folks just don't have it, or there's no cell coverage. You get what, 25 kilometers out of Merritt, there's no cell coverage. There's no cell coverage on a couple of the First Nations locations in those regions. You can't get to people. We have to build the relationships in the community with our partners. So that's sort of the scoop for me. We will continue on. Our projects will be able to be maintained, but we've also been able to eliminate things that just aren't going to work. So it's been, broadly focused, really super positive. And our quality improvement, what did I put up yesterday? I was out in Ashcroft because our accreditation's there tomorrow at mental health. And I put our certificates up on the wall. When they ask what our quality improvement projects are, we've got a certificate. So thanks for everyone for all your tons of patience and understanding, and a lot of appreciation coming back to the Boost team for the support and also our learning. Thank you so much for that. That's really it for me.
That's awesome. Thanks so much for sharing, Marcy. It's really nice to hear that. I'm assuming it sounds like you have to jump off. You don't have time for a couple of questions.
Yeah, I have till 9. I have to leave after 9.
Okay. So we'll open it up to any questions for Marcy from the group.
Hey, Marcy.
Hey,
thanks for sharing your experiences. I really loved how you talked about, the things that you tried that you're sticking with, and also the things that you tried that you found out didn't work, and you're sort of casting those off. My question is about the medications in Ashcroft. I know most of the other people on the call here, they have pretty incredible working relationships with community pharmacies. So wondering if you might be able to tell us some basics about what happened with the pharmacy in Ashcroft and what you're doing to help meet the need there.
It's absolutely phenomenal what is coming out of it, because I think you're going to see it across the province, to be honest with you. Yesterday I was working on the work, workflow for the nursing staff at the UPCC center. But yes, in Ashcroft, we have a pharmacy owner, not the pharmacist, the owner who will not under any circumstances to have anything to do with anything regarding oat. It will not happen while that person owns that pharmacy. Unless another pharmacy came into a small community like Ashcroft, it's not ever going to happen. And the pharmacist that is there had his hands tied. He's leaving, going back to Britain, and there was no ability to access methadone, nothing. So we had Dr. Miller coming from Lillooet, and stop me if I breach any boundaries here. Dr. Miller was having to drive from Lillooet with a truck, literally gray cases full of methadone, like carries. Everything had to be, there was no ability to do witnessing. It was impossible. So even if you needed your clients to be witnessed, you couldn't. Everything was a carry. So there's Dr. Miller bringing over a plethora, all the Sublicates, Boxone, methadone, 2 weeks worth. He's not there necessarily every week. He does 3 Tuesdays a month, but sometimes he's away. So if he was going to be away 2 in a row, he'd have to bring enough methadone for carries for 2 or 3 weeks. And to be honest, like, where did it go? And even when you're bringing 1 week's worth of methadone carries and they're being dropped off at the local motel, we're pretty confident that that particular individual is probably not getting all of it. Like, it, no blame or shame. It just, what else would he be doing? Like, there was no option. And now the UPC center's up and running, and already the feedback, the nurses, we're not going live till about the 18th of April or so. We've got the nurses that they're in training with some no nurse prescribers at this point, but we're getting them up and running, up to speed, getting the pharmacy things all up to speed. Salmon Arm, so Shuswap Hospital is going to be bringing the stock medications over to Ashcroft, but our oat medications are going to start coming from Kip Mallory and Kamloops, and we've got built a wonderful relationship. So what's really cool about it, to Andrew's question, I think, is how we've built community across Lillooet, Ashcroft, and Kamloops, and then bringing in Salmon Arm for all things, and how we built that foundation to support clients in the oat program there. And the fabulous thing, I think, to be following that is also to be doing some data collection and having a small project around that, because I think it's going to stem out to other UPCCs. The nurses have been really, there's only a couple of nurses. This is not a big UPC center, but, and they are being challenged. They're being asked to do the STI courses and the oat stuff. And we're just piling on all kinds of new things, and different kinds of narcotics receiving and sending, and you can imagine. But honestly, they're so excited because when the clients are coming in, they're not feeling like they're being watched at the pharmacy. They're building relationships with the staff. People are starting to get to know their names, and that feeling of being stigmatized is actually dissipating. So out of the ashes, so to speak, Ashcroft is turning into an exemplar. I think that we need to really look at perhaps modeling. It's been a lot of work, but once I think we've got that clinic, and I can't speak for the pharmacists, it was a lot of work for the pharmacists and for IH senior management. At the end of the day, though, the model will have been built for others, and that opens the door to, they're open 8 to 8. So what the nurses are finding is people are coming after 6. They're coming after hours. That's their best time to get a drive, or they don't really want to be seen during the day coming to the clinic. So honestly, I think it's a place to watch. Yeah. So sorry, long-winded.
Cole, you have your hand up there.
Yeah, thanks so much, Marcy. It sounds like you've learned a lot and some big wins. I like that you got the one physician on profile. I think that's huge. I've been thinking about how for many of our teams in Interior Boost and more generally in healthcare, it seems to often come down to the idea that, oh, we just need more resources. If we had like 2 more nurses, longer hours, things like this, that we'd be okay. I'm wondering how QI can fit into that, and you know, I think sometimes that is true, but wondering, do we still need QI in those circumstances? And did you have any experience with that? Like with your QI work, are you then able to go and say, oh, we learned that we need this and that? Just some commentary around that.
Yeah, sure, Cole. Yes, actually, I would say QI certainly. I think data collection, qualitative is a piece that's missing a little bit. Having the storytelling, the narrative piece, that you can go back, we can go back to management and tell the stories. So, but at the same time, you need the data to back it up. What we have uncovered, so we've got the peer support, and now we have a peer support coordinator posting out of Merit, but they will also look after Ashcroft and Lillooet and Lytton, I think, just kind of coordinating that peer support. And it's coming out of a different pocket, but at the end of the day, we've been able to have more rich, thick, and descriptive conversations with the funding side of things to say, hey, here's some information we're getting out of this QI project that shows the need, and we can back it up, and then we can storytell along with it. Here are the numbers. This is where our goals are. We can't achieve that without X, Y, or Z. And it's nothing phenomenally crazy. A peer support worker and then an extra $25,000 to have for hourly wages out in the more remote locations for peer support or life skills, something like that, someone to help accompany people to OAT, for example. So that's happened already because we were able to show the data to that point and then tell the stories. The other thing is with Ashcroft, what we're finding is it is overwhelming. There's only 2 nurses really usually in a day on a 12-hour shift at the UPCC. So the conversations come back around to, we probably need to think about having a nurse prescriber over there 1 or 2 days a week to take the load off Dr. Miller to bridge. So I think what we're able to do with QI is demonstrate the need for the bridge to peers, and the bridge between the prescriber, the physician, and the nurse prescriber and the staff. So we actually have been able to have good constructive conversations saying, here's the boost information. We don't have to manipulate it at all. There's no need for that. But I think the piece that I'm having to add is the narrative. Yeah.
Yeah, thanks a lot. Yeah, I guess it's also the ability to test something out before you implement it, right? So that nurse prescriber, maybe you're going to say, okay, let's try this for a month, see if our hypothesis is actually right, that this is really going to help. And then we have a story to tell and we can get the additional resources.
Yes, and I think we actually have been able to, at least the conversation came up early on in that project. However, we've been able to revisit it as we're getting closer to going live with that particular project. It's now being voiced more. It's like, yeah, I think we're going to need a nurse prescriber here to bridge. You know, even if it's just 1 day a week and they're coming out of a different location, say Lillooet or Merritt or something like that. So yeah, good. But it opens the door to the conversation, and it's super helpful. Yeah.
Thanks so much, Marcy. I think we will move along, but I really appreciate you coming on here. It's so interesting to hear what you've, all the work that you've done and what you've learned, as Cole mentioned. And I'm sure that you would be, maybe a good resource for other folks to reach out to if they have any questions about what you've talked about today. So if you don't mind, we can share your contact information, if that's all right, after, just to the Interior Health Boost group. Yeah, perfect. Thank you so much. We are going to move along and hop over to hear from Andrew. I'll pass it over to you, Andrew. I don't know if you have slides, but I will just quickly make you a co-host here.
Thanks very much. And I'm not going to take up too much time because I want to make sure Deb has the opportunity to, to take the webinar home here. So I won't take too much time. And hey, everyone. Nice to see everyone. Nice to see everyone at the webinar here. I think what my goal was for today was to give a bit of a reminder about the Mental Health and Substance Use Network and some of the tools that are available to people, working in any part of the MHSU spectrum, but specifically on substance use. And I don't have slides, so I'll just say, and I like talking. You all know that. So the way the elevator speech I give about the MHSU network is that we're this fairly big, let me show you this exciting org chart here. This fairly big group of people whose function in the health authority is to assist with strategic planning, and strategic planning in the last few years typically revolves around what new initiatives come from the Ministry of Mental Health and Addictions or the Ministry of Health. So there's, of course, the response to the toxic drug emergency and the millions of dollars that have been invested. Lots of that is all implemented through the MHSU network. There's also been investments in early psychosis education, eating disorders, and then in the last couple of years, this complex care housing and a lot of support for the vulnerable populations in our community. So all of that kind of falls underneath the network. And in addition to the strategic planning, we also manage all of the reporting. So anytime the ministry says, oh, health authorities, here's an investment that we'd like to make, and it always comes with some things that we have to report. So as we work with various teams and everything like that, we're also thinking about how we can capture the data. And many times that means, adding a tick box onto a form or something like that, or requiring a bit of somebody's time, monthly or quarterly or whatever to gather up a bit of information for us to submit. So you can see on this great big list, a whole bunch of people. The majority of the people are clinicians, nurses, social workers, and the like. Who've worked in frontline roles, frontline leadership roles. Many are managers from MHSU who've moved over now, and we really support the entire region. So I really find this rewarding because I get to see the wonderful things that people are doing in one community, and able to share those experiences or share the tips and tricks that people have used and share those with other communities. And the profile EMR is kind of an example of, seeing how everyone uses that and the ways that people have found it beneficial, and also some of the sticking points, able to bring that back to the profile developers and get it into their slow moving progress of changing EMRs. The different teams, of course, my team is we do all the substance use planning, and you can, if you can read the small thing, we not me, but my team created the youth substance use model of care. So there was a recent investment for youth substance use services, and this is the first time that that Interior Health provided youth services within mental health and substance use. So there was quite a lot of work went into developing this whole model of care, so that clinicians would go into the work knowing exactly what their roles are and what the type of work that they're doing and how they're going to work with other agencies who support youth who are accessing services. We also develop and provide a lot of clinical education for people. And I'll switch over to the very exciting Inside Net here, where if you haven't looked on here, there's it's so easy to just get overwhelmed by it and never look at it. But if you do have a moment of a day, and you do go digging in there a little bit, you can find something that we've called the Substance Use Treatment Toolkit. And within here, there are a number of things. that again, you can get lost. You know, we've put in kind of links to all like the provincial documents, the national documents, and lots of research and everything like that. But we've also, I'm looking for opiate use disorder here. So we've also, you know, in addition to linking lots of information for people, we've also put in lots of information to support people. So Marcy, you're talking about, you know, getting Dr. Miller set up on profile and everything like that. You know, we've created a bunch of resources up here. So for example, you know, I consulted on a treatment retention resource that would be useful for OAT clinics, right? So this is right from one of the earlier change packages of, you know, when you're first, sorry, my zoom in, zoom out is hidden here. There you go. So the different treatment stages and everything like that. It provides a few ideas to kind of look at for doing quality improvement. And then it also goes into some of the nuts and bolts. Goes into some of the nuts and bolts about the different things. You know, thanks to Sam and the Kelowna Clinic here, they've done tons of work in helping people, you know, ensure they have proper medication coverage. So you know, we develop and can add to these fact sheets to support anybody working in OAT to kind of not have to reinvent the wheel on all of these things that are standard practices within our services. The final thing that I wanted to share is on the public-facing website. You know, if somebody is looking for services, if a family member of somebody who uses substances is looking for services, we've you know, my colleague Sherry, she's done a ton of work in making sure that the public-facing website has tons of information in here. And within here, there's a number of substance use fact sheets. You know, if you go to Google and you're looking up, you know, detox and interior health, you'll find millions of different resources, links, and all that kind of stuff. So what we tried to do was put together kind of these focused fact sheets that link people to the best information that's available out there. So if I click on the OAT one, for example, you know, it gives a whole bunch of information for people and for families, as well as for health professionals. So when we developed these, we shared these with lots of community agencies, you know, lots of the, you know, the Ask Wellness and the, you know, John Howard and all these agencies who work with the same people as we do. This is kind of a one-stop shop for you know, everything related to OAT and everything related to all of those other health topics. So I encourage you to look through some of these and see if they're useful. We've also put in lots of videos. There's been some great videos developed by different health authorities over the years, including Interior Health. So we've tried to pop in some of those videos in there as well. And that's it for the boring tour of a couple of org charts and websites. And also want to, you know, put it out there too that anyone who's, you know, we have great educators, nurse educators, and social workers who are educators who would be more than happy to come to a team and help them link to some of these resources, help arrange different types of education. You know, if it's like motivational interviewing, for example, trauma-informed practice, these are things that our educator team and our knowledge coordinators love to get out there and love to help strengthen people's knowledge in these kinds of areas. The final thing, I guess, is our team runs a couple of community of practices. So for people who are working in like overdose prevention services, so that's like overdose prevention nurses that exist in a few communities. The episodic OPS nurses, there's a regular community of practice that brings people together from across the region. Maybe some of you are part of it. And then Amanda, our clinical nurse specialist, she runs the nurse prescriber community of practice. So she helps keep all the nurse practitioners, you know, sharp and reporting their data and highlighting their good work to the organization. So I'll stop there. Happy to answer any brief questions and happy
Thanks.
to receive calls or emails.
Thanks, Andrew. Does anyone have any questions for Andrew? Kind of popping into your head. I don't see any. Okay. As Andrew mentioned, though, he's happy to take any questions over email if you have any, if you can think of any. Thanks so much, Andrew. Thank you. So we're going to move along here. And next up, we have Deb Bailey. And as I mentioned, Deb is a family member, and she's also a member of Mom Stop the Harm Vancouver. And she has been involved with Boost for quite some time. And she's going to be speaking to us a little bit today. So Deb, I'm going to pass it over to you if you're ready.
Good. You can tell I haven't been on Zoom for a while. Can everybody see that screen that I just put up? There's horses on there. Okay.
Yes,
Don't
we can
worry.
see
I am at the right talk. It'll all become clearer in the end. It's really great to be able to talk to people out there that are on the front lines. I know you guys are dealing with folks in what might be, the most difficult times in their life, and it's sometimes hard to leave your work at home, and you might carry it along with you in your invisible backpack. So I just wanted to talk about that and the power of what you're doing. So during a recent snowstorm, that we had, I was stranded on Main Island. I have 2 mini horses, there they are, that I keep over at my sister's farm. And so I'm often going between Maine and Galliano and the mainland. My sister, who is the farmer on the farm, had a clutch of eggs that were just starting to hatch. And we thought in the morning that we were going to wake up to 40 new little fuzzy peepers. But instead, the next morning we woke up and there were only 3. So sometime in the middle of the night, the snow started to fall, and it often happens on the Gulf Islands. The trees started to break and the power went out. So the incubator went off and lost heat and stopped rotating. The little eggs that were there were all cold, and we were, it seemed a bit hopeless for us, but we held each egg to our ear and we listened. I don't know if you've ever had the opportunity to do that, but when the chick is ready, you can hear it peeping inside there, scratching. And we heard some faint peeps at first, just in 5. And 3 of those hatched, and the other 2, they had a little bit of a problem. So, yeah. No, I'm just trying to, a little bit of a problem, but in the end, it was okay. So here are our eggs, the actual real eggs, and here they are. The incubator stopped and nothing's going on, and we're thinking, oh gosh, all these poor little chicks have died, but some of them did hatch, and so we ended up with a 3 that were hatched, and some that really needed more help than others. But we would mark the ones that we thought were goners. This is not going to work at all. We would mark them with an X because the eggs had been very cold. But throughout the day, some eggs that we'd given up on and marked with an X started to peep, miraculous, inside their shells for what they'd been through. And so we had to help some of them out. Their needs were all different, but we assessed and triaged them all. And at the end of the day, we were left with 40 little fluffball chicks. Miraculous. But that meant that some of the chicks just didn't survive. We felt sorry about each chick that hadn't made it, but we knew that we had done the best we could with the skills and the materials that we had. So as I was thinking about talking with people, it struck me that this is kind of a metaphor for what you do. People struggling come in and you look for the clues, you listen for the peeps, the faint taps that they might be ready for an oat background or an oat treatment. But the big thing I think, and we heard it earlier today, is you express acceptance for people when they come in for help. Each person has setbacks, and sometimes it seems hopeless. And like the X eggs, you treat each person with the possibility that they might make it through. And you can have hope for them really when others do not. And I think that's really a powerful thing. you know, sometimes this work can be really discouraging, and it's 10 steps forward and 2 steps back. And you might wonder, why did I ever give up my job at Starbucks? You know, life was simpler then. But sometimes it's not the people that are, you know, the problem, but the limitations imposed upon us by our systems that haven't caught up to real life in the trenches. And there are resources out there that you don't have. Looks like you have a lot, but there's things, you know what they are that you don't have. So last year, I spoke to the standing committee of the legislature on health. That's a bunch of MLAs that were going around talking, listening to people. And I told them about my daughter, whose name is Ola, and she died from using drugs which contained fentanyl. After I told her story, some of the committee members dabbed at their eyes because it's a sad story, just like the 11,000 other ones in BC. And then I told them something that I'd left out. Ola died in 2015, some 7 years ago. We knew what killed her then, and still people are dying of the same thing in overwhelming numbers. Change was just too slow, and I think for some of us that's discouraging too, that we're going to look back over this time, you know, historically and say, what were we thinking? And it can be really difficult to be at the receiving end of this slow, ponderous system that is resistant to change. So I'm going to tell you a really condensed version of Ola's story and the little legacy that she left behind. Ola died in 2015, as I've said, just a few days before Christmas. Ola was 21 and she'd struggled with addiction for several years. She was adopted at age 3 from Russia, and she came with many burdens, not of her making. She was one of those, would she make it? From the beginning, though Ola was a force of life, lively, funny, friendly, loving, athletic, determined, and game for anything kind of gal, she had a happy childhood. When she was 6, she told us all the activities that she wanted to be in. And I said, well, wait a minute, what do you really want to do? And she blurted out, girl hockey, mommy. Well, her dad and I were not hockey buffs, so we didn't know what the blue line meant, and offside still confuses us. But girl hockey it was. Ola's first piece of equipment was her helmet, which she slept in for a couple of nights. She was a dancer. She loved to ride horses. She achieved a black belt first dan in a martial art. She became a warrant officer in cadets. She could play the sax and the bagpipe. Most of all, she loved being a goalie. Hockey is my life, she used to say. She managed to graduate BC with a BC dogwood, even though her struggles with addiction had already begun. But Ola, my Ola, had so many burdens that made her terribly at risk for addiction. She had early childhood trauma, early neurological challenges like ADHD and learning disabilities. And then if that's not enough, at 13, a mood disorder kicked in. She received treatment, medication, and counseling throughout her short life, and her large and extended family accepted her. Her dad and I used to tell her, you know, you're just our bestest thing, but you know, Ola was an ex-egg and she needed support from all sides. But like most others who struggle with addiction, her story is full of twists and turns that go through hopes and horrors. And at some point when she was 15, and unbeknownst to us, a 50-year-old man approached her at a bus loop. Ola had poor social judgment, and she tended to think that anyone that was nice to her was okay. Obviously, this guy was not okay. And he coached her not to tell us about him. Now, this guy was a heroin and a meth addict, and it's a long story with the end result that she became very addicted through her association with him. But from the beginning, Ola believed that the determination she had shown through many of her achievements would help her escape the iron grasp of addiction. She tried many times to break free. She went into many programs, cried over her failures. One time in despair, I found her kind of in the woods after a big meth extravaganza, and she said that I should leave her and forget about her. You know, addiction doesn't run in my family as it did in Ola's biological family. My bio family has different genetic email. So none of us were familiar with what Ola was about to go through. Her dad and I lived the next years with horrified bewilderment. And so I get it when other people, maybe other family members of the people you see don't get it. They don't understand the power of addiction and the fierce and unrelenting hold that addiction has. But, you know, addiction can trump a lot of things. It's just really a beast. And this is out there, and this is what you're fighting. It isn't totally a decision that a person can make in their mind and just do it, because powerful forces are at work with those who are addicted, and you need to throw all the resources you have at them. And this is what you do. You offer hope where there once was none, to both your client and also to their families. So I'm going to tell you about the part of life, part of Ola's life that involves Suboxone, and that was in her last year. In the fall of 2014, she'd been to several programs in an attempt to get methadone. Remember that in 2014, methadone and Suboxone were both controlled substances and linked. Methadone was the drug of first choice. She went for many meetings, but nothing happened at the first center. She went to another program, and as she walked out of the office, the worker reminded her cheerfully that things would not happen overnight. It might take up to 2 weeks. Of course, she didn't make it for 2 weeks, pulled in again by the lure of addiction. So in January of 2015, Ola started to purchase methadone from her stable friends. I asked her if the bottle was sealed when she got it, and she said no, so who knows what she was getting. She fell and injured her leg, and it didn't get better. She had ended up in the hospital, and it turned out she had introduced into her bloodstream a horrible infection, and she ended up needing surgery on that leg and heavy duty antibiotics. So she was there in the hospital for 2 weeks on intense antibiotics. And then when she was set to be discharged with the home IV program, she stood up to put her pants on and collapsed in excruciating pain because her femur was broken. So effective was this pathogen that it disintegrated her bone, the femur, the strongest one we have. And so surgery again, where an external frame with 4 big spikes was inserted through her skin and into her leg. And then a week later, more surgery to insert an internal frame. And she spent a total of 5 weeks in the hospital. I asked her at one point during her stay if these experiences had convinced her that she'd had enough of drugs. Of course, she said to me, but to my sister, she said, even after all of that she was worried she would relapse. But before she was released, the addiction doc at the hospital recommended Suboxone and gave her a 4-week take-home supply, which we, her parents, were supposed to manage. That's okay, we were used to that. And Ola's response to Suboxone was amazing and hopeful. Although she was still very ill, what we could see pretty soon was that her drug-seeking behavior and thinking subsided and stopped. No matter, it wasn't, the most important thing in her life anymore. And she started to talk about the future a little bit, something that she hadn't done for a long time. It was pretty amazing. But she was transferred to a community addiction doctor who really didn't get it. And that Ola was an ex-egg. She needed help. And overall, this doc took really no interest in her. And at one point said to me, well, you can get people to look after people like that. I think he thought she was low intelligence or something. He didn't even check. But so on the 4th week of managed carries, remember she's got carries, we're giving it to her, it's working really well. Ola went into her appointment with the doc with a cane instead of crutches, and the doctor wrote her a prescription, only this time with no warning or discussion. DWI was required. Ola was very discouraged about that. I took her for her first DWI, which Ola viewed kind of as a punishment. And so in plain view of shoppers, you know how it goes. She saw the pharmacist, she's given her pills and a little glug of water, and then asked to show, open her mouth to show the pills were gone. I knew her, I recognized her body language, and I thought, uh-oh, trouble. I tried to make light of it and say, well, that was pretty fast, but Ola just flatly said, well, I might see someone I know. She was deeply, deeply, deeply ashamed of her situation. Addiction had surprised her, and she often told me, I don't know how I got this far in. So after that DWI experience, and this might sound familiar, Ola said she thought she didn't need Suboxone anymore. She could continue it on her own. She would be okay. But she wasn't okay. The rubric had been this: on Suboxone, no overdoses; off Suboxone, overdoses. And so she had 3 significant overdoses in the next few months. And every time she was released the same day from the same emergency room, no follow-up, no report to her primary care doctor or her addiction doc or her psychiatrist, and no Suboxone. So it just was really obvious to us that Suboxone had been so helpful for her. And I didn't understand why, DWI was required. And, this 3 significant barriers or 3 significant overdoses. Why put barriers up for people, that made the delivery of this stuff difficult? she had a workable alternative. We didn't mind giving her her meds. So finally, I talked to Ola about considering going to a different clinic with a different doc that was willing to work with her, and she agreed. And she said, yeah, Suboxone had helped her, and she would go. We would go look for somebody else. It was Christmas time, and we planned to go right after that. On December 22nd, Ola went Christmas shopping and never came home again. On the morning of the 24th, 2 young cops walked up our door to tell us that Ola was deceased. And that's how my husband and I came to be at the morgue on Christmas Eve. So, I mean, I can't tell you in words what it's like to lose a child, and I hope that none of you ever know. And sometimes, I really do despair because I think, what is it? What is it that we need to do? What is it that we're not doing? It's been 7 years now, and the moral stigma and social stigma of addiction and drug use and drug users still exists. I listened to the pharmacy story there. At Ola's memorial, we had a little angel token and a card and a wish. Her tearful cousins gave them out to people, and the card said, "The world of addiction is dark and gnarly. Please, in Ola's honor, do an act of kindness and throw some light into the world." And I think that's what you all are doing. You're throwing light into the world that was formerly dark, and you're engaging people in a way that they might not have been engaged with. You believe, you hope, you encourage. Of course, there's despair at times, but collectively and individually, you're making a heck of a difference to some of our eggs, even the X ones that you might give up on. So you can't underestimate the power of what you do. And I actually think for those of you that are looking at this superpower, you have hope. You just have everybody's best interest at heart. You have knowledge, you have connections. And I know it's discouraging, but OAT can work sometimes. And it's the best that we have right now. And I think if you listen to, it's my firm belief that had Ola been able to get Suboxone, she would have had a much better chance of being alive, like so many others. So, whatever you're doing to help people get OAT, you could be saving their lives really, really seriously. And never forget that or give up on the X eggs. So Ola's little legacy is, I just put it in there because that's sometimes one of the reasons that I talk, is that she died in 2015. And then 2016, we petitioned the Attorney General, Judy Wilson-Raybould, and she wanted to help us, and she did. We were petitioning her about Suboxone. January 29th, 2016, on CBC National News, there was not an article, but a little show about Ola for lack of a pill. And then, and lo and behold, July 5th, 2016, the BC College lifted their outdated response on Suboxone. I don't think Ola did that, by herself, but I do think that her little face on national TV helped to tip the scale a little bit. So to me, it's bittersweet, but that's a little bit of her legacy, and the way she's helped and the way she's thrown some light into the world. So I just thank you for listening. I thank you for what you're doing. And I never forget, these 4 individuals that you see here have all passed. 3 of them couldn't get OAT when they really needed it. They died a while ago. And so just the power of what you're doing, just remember it. And I think it's wonderful that you're all involved and that you all care. Okay, thank you very much.